I'm excited to introduce our speaker this morning, Dr. Katherine Schaumberg. She got her PhD in clinical psychology from the University of Albany, and then multiple postdocs at Drexel and at University of North Carolina before coming here to the University of Wisconsin, where she's a assistant professor in the psychiatry department, specializing in eating disorders. She's a NIH-funded researcher, and we're very excited to have her join us this morning to teach us about eating disorders.
All right. Well, thank you, everyone, and good to see many of you. So today I'm going to be talking about understanding and addressing eating disorder vulnerabilities across the lifespan. And before I get started, I just have a couple disclosures. I'll go through the disclosure slide. If I can advance, can I just
the arrow
down?
Nope. Probably just look like I'm gonna use the mouse. Or connected.
What in the world? Okay, guys, mouse. All right. So as far as funding, much to the chagrin of the Grand Rounds Chair, I have no relevant financial relationships with eligible companies to disclose. I also will not be discussing any unlabeled or unapproved uses of drugs or devices, though I will be discussing some just emerging research in the field. Some other disclosures I have are, first of all, I'm not an MD, so I am going to be talking about ovarian hormones in different places, and you all are the experts on those. And so I'm just kind of presenting the research as we know in eating disorders, but you all probably have a better mechanistic understanding of a lot of that. And then as compensation for my talk today, the Grand Rounds Chair will be taking me out for cocktails tomorrow. Okay, so our objectives today are, I'm going to kind of take us through the lifespan. So I'm going to start in childhood and explore childhood anxiety as a predictor of eating disorder risk in adolescence. And then we're going to move into the pubertal period and talk about the heightened risk for eating disorders during female puberty. I will then talk a little bit about the obstetric and gynecologic complications and comorbidities associated with eating disorders. And we'll finish with talking about the menopause transition as a potential high-risk period for particularly binge eating. I just want to note here, throughout this talk today, I'm going to be focusing on eating disorders in females and women and girls. Eating disorders are also present and do happen in males, but there's two reasons I'm focusing on females today. One, that's the population that you all see most commonly, and two, there is a kind of tilted prevalence in eating disorders where, depending on the disorder, it's between 2 to 1 and 9 to 1 affecting women and females. So I'll be focusing on women in this talk. Before we get started, I want to refresh you all, because I know for many of you, it may be a while since medical school, and it may have been a while since you've thought about or been really kind of like thinking about the diagnostic criteria for eating disorders. So broadly, I'm not going to go through the diagnostic criteria for everything, but broadly, eating disorders are characterized by disturbances in eating and related thoughts, preoccupation with food, body, and weight often, and it often include also some nutritional disturbance. And I have the different eating disorders up here on, I guess it's for the folks in the room, it'll be to the right of your slide, and the lifetime prevalence and the age at peak onset. So when I say person with an eating disorder, if you close your eyes and just kind of think like person with an eating disorder, an image that pops up, I'm going to guess that you think of someone with anorexia nervosa. For most people, that's kind of the eating disorder that comes to mind most readily. It's the most present in media and sometimes our healthcare education as well. But what you'll see on the slide is that the lifetime prevalence for anorexia nervosa is about 1%. So it is a rare but very present disorder in the patients that you'll see. But if we look at the other eating disorders, we see that there's actually higher prevalence of bulimia nervosa, binge eating disorder, and particularly this thing at the bottom called OSFED, which stands for other specified feeding and eating disorder. And that is just everyone who maybe doesn't fit neatly into one of those other eating disorder buckets. So to just review quickly kind of what I'm talking about when I talk about these different eating disorders. So anorexia often is associated with a significant weight loss to the degree that someone becomes underweight if we're thinking at the population-based level, so underweight, and there's fear of weight gain, body image related disturbances, and often a refusal to gain weight and to become at that, at a healthier weight range, and a lot of dietary restriction. Bulimia nervosa includes episodes of binge eating. And so what is a binge? It's eating an unusually large amount of food given the circumstance. So Thanksgiving, for instance, does not count as a binge. But in a circumstance where you wouldn't necessarily be expected to eat a large amount of food, it would be an unusually large amount of food given the circumstance within a 2-hour period, and feeling a lot of shame, guilt afterwards, and feeling a loss of control during that episode. So you probably know some 16-year-old boys that eat a whole pizza, and they don't feel really bad about it, and they feel just fine and probably in control. But that loss of control piece is really important. So having that binge episode, and then also having a purging or compensatory behavior that occurs after the binge episode. So this can be vomiting, laxative use, excessive exercise, and fasting are most common compensatory behaviors, and those would all occur after the binge episode or in close proximity. Binge eating disorder is having those experiences of binge eating, but without those compensatory behaviors. And for binge eating and bulimia, those episodes that I'm talking about are happening at least once a week for about 3 months. ARFID, which you may or may not have heard of, is called, the full name of that is avoidant restrictive food intake disorder. And for the purposes of today, I'm just going to say that is kind of like extreme picky eating without the body image component. So folks who are so picky that it becomes very difficult to meet nutritional needs. And then I've also talked a little bit about the OSFEDs. That's kind of folks that don't necessarily neatly fit into one of these other categories. One that I'm going to highlight that we're going to come back to is this AAN, which is atypical anorexia nervosa. And that is when individuals exhibit all of the other signs of anorexia nervosa, so significant weight loss, dietary restriction, fear of weight gain, body image disturbance, but they're not meeting an underweight criterion. And that is something that clinically I have been seeing as more like typical anorexia nervosa, that we actually see more of that presentation where folks are meeting all the criteria, but not necessarily getting to that underweight status. Another thing I wanted to just highlight on this slide is when I have you close your eyes and think about that person with an eating disorder, the first thing that comes up, in addition to having anorexia nervosa, another thing that might have come up is what we call the swag stereotype, so the straight, white, affluent girl. And I want to note here that eating disorders affect individuals of all ages, weight statuses, socioeconomic backgrounds, genders, races, and ethnicities. And to kind of put a fine point on this, this is some recent research that has been coming out, and there has been more and more research into this concept called food insecurity recently, and particularly how that associates with the presence and prevalence of eating disorders. And you can see on the slide here, as food insecurity in the house increases, so folks who are either individually food insecure themselves, and then having a child in the home who is food insecure is considered to be the highest level of food insecurity, that we see that percentage of individuals with an eating disorder increase to the point where it's up to 18% when you're experiencing childhood or you're experiencing children in the home having food insecurities, and this is among the parents. The eating disorders that we typically see in this population are bulimia and binge eating disorder. And you can think about reasons related to food availability and inconsistent food availability that might spur the development of eating disorders in this population. So this is just to put a point on, while we think about eating disorders, that swag stereotype, that's not necessarily true, and it's not necessarily how patients are presenting. So another thing I just want to highlight here is that eating disorders are a serious mental illness with high levels of medical and psychological comorbidities. For anorexia nervosa, for instance, about 5 to 10% of individuals will die within 10 years. About half of those will be complications from the disorder. The other half will die by suicide. And so these are very lethal and very serious mental health conditions. Okay, so now that we've covered all that, let's get into our childhood stage of things. So I want to talk here a little bit about anxiety and how childhood anxiety is one comorbidity that often occurs with eating disorders, and individuals who experience childhood anxiety are at heightened risk for then going on to have eating disorders in adolescence. And there's a lot of research around this topic, but I'll just kind of hit a couple of things here. So the first is that we're looking at within samples of individuals with eating disorders, the prevalence of anxiety-based disorders, of any anxiety disorder, is really high. So we're talking about 50 to 80% of individuals with eating disorders will have a comorbid anxiety disorder. And common ones are social anxiety disorder, obsessive compulsive disorder, and PTSD. But all anxiety disorders are present at pretty high rates. And so what this this comorbidity specifically, but then comorbidity across all psychiatric illness, has led to some interest in research and well, how are these things clustering together, and maybe how is this risk clustering together throughout childhood and throughout development? And it's both phenotypic and genetic evidence that supports an association between eating disorder and anorexia risk. And one example of this is something I'm going to call the high top model. And so you all are probably familiar with the DSM, or Diagnostic and Statistical Manual of Mental Disorders, kind of how we categorize psychiatric illness. And something I want to note about the DSM is that the way that the DSM is developed is about every 10 to 15 years, there's a bunch of psychiatrists that get into a room, kind of a smoke-filled room, and they come out, they go in, and then they come out and they've decided the new criteria, right? So psychiatric diagnoses are informed by research, but solidified by consensus, and they change with every new iteration of the DSM. So it's not necessarily in the same way that we think of other, a lot of other medical conditions where you're kind of bottom up defining the symptoms. They're also syndromal, so it's a checklist of symptoms is kind of how you get to a diagnosis often. And there are alternative ways of thinking about, well, how do these symptoms that often overlap across these disorders really show up in the real world? And one way of doing that is taking all of these different symptoms, so eating, anxiety, mood, and saying, okay, how are they actually showing up in patients? And when we do that, we actually find that there's more of like what we call a hierarchical structure, and that eating disorders and anxiety disorders, along with depression and sexual function disorders, kind of cluster together. So if you're at risk for one, you're probably at risk for the other. And if you're experiencing symptoms of one, you may be more likely to experience symptoms of the other. And we call this spectrum the internalizing disorders and the internalizing spectrum. And so that's some evidence that that eating disorders and anxiety disorders tend to cluster together when we're looking at empirical classification. We also know that anxiety symptoms in childhood predict adolescent eating disorder symptoms, which I'll talk a little bit more about. Another thing is we know that eating disorders and anxiety-related disorders are co-heritable. So the genetic correlation at the SNP-based level between anorexia nervosa and any anxiety disorder is about 0.23. And one of the highest genetic correlations in psychiatry is the genetic correlation between anorexia nervosa and obsessive compulsive disorder at 0.47, which suggests that about half of the genes that are associated with anorexia nervosa are also associated with obsessive compulsive disorder. So we see some co-heritability there. And then this is some work that I did a few years ago on looking at anxiety at age 10 and how that associated with eating disorder diagnoses at age 14. And we see that physical anxiety, so things like at age 10, feeling like having your stomach in butterflies, heart racing, palms sweating, that physical sensations of anxiety, that having more of that at age 10 was associated with higher levels of bulimia nervosa at age 14, and that being a worrier, having a lot of worries at age 10 was associated with higher levels of both anorexia nervosa and OSFED at age 14. So we see this longitudinally as well. So I talked a little bit about childhood. So one thing I just want to put a point on there is that childhood anxiety may be a risk factor for adolescent eating disorder. So when you're looking at patients and and maybe even if you're seeing younger patients and the pubertal transition, that's maybe a risk factor to be looking out for in terms of eating disorders. So now we're going to talk about heightened risk for eating disorders during female puberty.
No, I can't take over.
I am going to talk first about a twin study that's pretty cool. I am not sure kind of what the lay of the land is on your behavioral genetics, but we're going to keep it really simple. So a twin study in behavioral genetics, what we do is compare monozygotic twins and dizygotic twins in terms of their phenotypic similarity to each other. And so those terms I know I don't have to tell you, but and I know that the twin stuff is a little bit more complicated than that, but for the purposes of this, we're just going to talk about monozygotic and dizygotic. If monozygotic twins are more similar to each other in terms of their phenotypes, in terms of their the presence of eating disorders, more higher concordance among the monozygotic twins than in the dizygotic twins, what we can say is that there is a genetic influence on the phenotype, right? Because the monozygotic twins are sharing 100% of their DNA, the dizygotic twins about 50%, and so if there's a differential, and presumably the environments are roughly equal across, so if there's a difference and the monozygotic twins are more similar to each other, that suggests a genetic influence. So I have on the bottom of the slide a couple of things I'm going to be talking about, and that is, so A is our additive genetic effect, C is our shared environment, so the environment that is shared across the twins, so things like the family home environment, and E is our unique environment, so say like one twin does dance and the other does soccer, like how do those unique environments shape the differences or similarities in the twins. So by comparing monozygotic twins and dizygotic twins and those concordance rates, we can kind of parse out A, C, and E and determine the association with eating disorder risk in this case. So at age 11, what we see is that the additive genetic effect, so the genetic component of eating disorder risk, and this is, I guess disordered eating, is small. It's about 6%. Most of the risk for disordered eating symptoms at age 11 are due to environmental factors, about half of that shared, half of that unique across the twins, but there's little influence of genetic risk. When we move to age 14, that changes completely. And this is where we see about half of the genetic risk for the eating disorder phenotypes. And we also see an increase, obviously, in disordered eating from 11 to 14. But about half of the risk for the phenotype is due to genetic factors. So the monozygotic twins are much more similar than the dizygotic twins at age 14. That was not the case at age 11. So there's something happening during the pubertal transition that is essentially turning on this genetic component of risk for eating disorders. And then that is stable at age 18. So we kind of see the same thing at age 18. So Kelly Klump, who I'm showing up here, who's kind of this giant in the field, a lot of my slides today are based on her research, has done some studies on puberty, and I'm just going to kind of go through her main findings recently. So first of all, puberty is a risk period for eating disorders. So we see increased risk specifically for girls. Before the pubertal transition, boys and girls actually don't differ that much in their disordered eating. It's low across both sexes, but they don't really differ that much. and until the pubertal transition. The cool stuff that Kelly has done also is she'll take like 12 and 13-year-olds who, you know, some of them are more advanced in puberty and some of them are less advanced. And it seems like the pubertal timing specifically, not just calendar age, is responsible for that increased eating disorder risk. So early timing and advanced development is associated with higher risk. There are potentially both psychosocial and biological factors that are influencing this. So from a psychosocial perspective, perhaps body dissatisfaction and low self-esteem may be increasing. And then in the biological side, ovarian hormone shifts may be at play. And we're going to talk a little bit more about those as we go through the talk. The pubertal impact is stronger among girls, as I mentioned, and testosterone may exhibit somewhat of a protective effect for disordered eating. Okay, I'm going to talk briefly here about disordered eating in trans and gender non-binary youth. And the reason I'm doing that is because if we look across like all demographic groups, trans and gender non-binary youth are actually at the highest risk of all demographic groups for eating disorders. So prevalence rates are around 16 to 18% in these youth. And this is just something I want to highlight for you all because I know, you know, some of you may be seeing trans and gender non-binary youth in gender clinics and other places. So this is a population for you all to be aware of. Some key drivers may be gender dysphoria. So for instance, restriction may be serving as a mechanism to suppress secondary sex characteristics for folks who are experiencing gender dysphoria. There's also obviously minority stress that increases risk for all psychiatric illness among trans and gender non-binary youth, and eating disorders are no exception. The potential hormonal impacts have been underexplored, so we don't know much about that. But obviously, you know, hormones and changing hormones can have an impact on both appetite and body, and so there may be kind of elements of this that we don't know as much about, and we need to know in the future. There's also an association between weight status, higher weight status, and risk for eating disorders, and so to the extent that these youth are, you know, have higher weight status at baseline, then they may be at higher risk for eating pathology. So just some clinical insights and practical recommendations for this population. Eating disorder symptoms often persist without addressing the gender dysphoria, but receiving gender affirming care does not in and of itself completely improve or fully resolve the eating disorder symptoms. So we often recommend therapy that's focused on eating disorders in addition to just receiving gender affirming care. And family support can be critical for helping these adolescents. And then practical recommendations are screening, particularly in places where you're seeing trans and gender and non-binary youth, and potentially providing some anticipatory guidance, preparing you for like the impact that hormone therapy might have on appetite and body changes. Okay, so I told you I was going to come back to this idea of atypical anorexia, and that's where we're going to kind of come here. So if there's one point that I would like you all to take away from this talk, it's about you know, kind of challenging that swag stereotype, challenging the idea that eating disorders happen or only show up in folks who are underweight or in malnourished bodies, and thinking about more broadly who has an eating disorder. So when I say who has an eating disorder, our media, attitudes, and healthcare education often kind of have this stereotype that comes up of severely malnourished, underweight, often white affluent girl. But there's a lot of attention now to atypical anorexia nervosa, which is meeting all of the diagnostic criteria for anorexia nervosa: restriction, low weight, and fear of weight gain, with the exception that despite the significant weight loss, the individual does not reach low weight. And this is, so these two images are from an article that ran about 2 years ago in the New York Times, highlighting the struggles that folks with atypical anorexia, folks in higher weight bodies with eating disorders, have often accessing care, and that they may not receive or be taken seriously in care when they are presenting with an eating disorder. So we know that eating disorders are underscreened, underdetected, and undertreated in non-underweight individuals. Now you might say, well, but is atypical anorexia really the same as anorexia? Like, is it really as serious? And all the research to date kind of suggests yes. That they're pretty much in terms of their seriousness, that they're both very serious. So this commentary came out that atypical anorexia is not atypical at all. And like I said at the beginning, it might be actually what we're seeing more of if we are opening our eyes in clinic. There's actually few differences in psychiatric comorbidities and treatment outcomes among individuals with atypical versus underweight anorexia. And that we may need to start, that all of this may need to lead us to thinking about rethinking the BMI criteria specifically for anorexia nervosa and how useful that actually is. So I'm going to read a quote on the right over here. The criterion of BMI does not represent all the relevant symptoms related to atypical AN and is based on arbitrary thresholds. And that is totally true. The 18.5 or whatever it is, it's an arbitrary threshold, and it doesn't necessarily give us any additional information on how sick this patient might be or what they might need in terms of care. So currently, the BMI cutoffs for anorexia, for instance, for diagnosis and recovery are centered on population-based norms. And the premise behind these cutoffs is that this distribution that I have on the right is the distribution of people with anorexia, right? Of restrictive eating, that's what that distribution looks like. So you have a high cumulative distribution of people with low BMIs who have restrictive eating. And then as you go forward through the BMI spectrum, not a lot of people have restrictive eating. And so the idea is like, okay, let's just cut it there and screen all those people who have really low BMIs, right? But the issue is that in the real world, this is maybe what the patterns look like. You'll notice even I have like a little dip there around 18 to 21, that there's some literature that suggests that might be because there are folks who are just constitutionally thin who are actually mixed in there with lower risk for eating disorders. And that so what this leads to is there's really nowhere on this entire graph that I could make this cut that would optimally balance sensitivity and specificity. So what I think we need to do is, instead of thinking population-based in terms of whether we need to be concerned about eating disorders, let's think more individually. So could we use more individually tailored weight trajectory expectations for where someone should be? And we have all this information. We have growth charts. We know where people have been in the past. So let's use that data. And this is just some work that I've been doing on what actually others in the field, but have called weight suppression. And so this is the difference between an individual's highest ever weight status and their current weight status. And this can be kind of derived a lot of different ways. But for conceptually, this actually seems to associate with eating disorders and eating pathology much more tightly than does raw BMI. Just some data on this in adolescents. So this is a group of adolescents, 3,000 boys, 3,000 girls across ages 13 to 16. And I looked at who had a significant weight drop and who reached underweight status or who was underweight from ages 13 to 16. And we see that about 25% of individuals had a significant weight drop, but only a small portion of those, so only those in the green, reached underweight status. So there's a big portion of individuals during adolescence who might be having a weight drop but not reaching that underweight status. And then if we look at how these groups associate with, how this associates with eating disorder risk, and this is what I'm going to call maladaptive weight control behavior. So fasting, vomiting, or laxative use in the past month. That group that for girls that had a BMI-Z reduction, so they had a significant loss, but were not reaching underweight status, were actually at the highest risk for these maladaptive eating disorder behaviors. So more evidence that we need to be thinking kind of individually rather than at that population-based level. All right, so just to wrap up the puberty section, so 3 things I kind of wanted to highlight in there were the, think individually when you're thinking about people's weight statuses and BMI trajectories. If you're seeing trans and gender non-binary youth, that's a high-risk group. So, make sure that maybe a little more attentiveness to screening. And then puberty is a high-risk period for the development of eating disorders. And going back to the childhood thing, particularly potentially for those who have childhood anxiety. So let's move into the part that you all want, the obstetric and gynecologic risks and comorbidities. And for this, what I'm going to do is we are going to have a little quiz. So residents, I will be looking at you. So what I'm going to do is we have anorexia nervosa, bulimia nervosa, and binge eating disorder here on the right of the slide. And then down here we have the comorbidities. I'm going to read off each one, and as I read, sorry people in the on Zoom, you're not going to be able to quite get the full participation on this one, but as I read off, I just want you to raise your hand or keep your hand raised if you think that this is a comorbidity or complication, and then I will show the answers at the end of the row. So we're going to start with amenorrhea. Who thinks that is a comorbidity or complication of anorexia nervosa? All right, bulimia nervosa. Binge eating disorder. Oh, the faculty win. It was all three. All right, PCOS, anorexia nervosa. Bulimia nervosa. Binge eating. Yes, good job on that one. Endometrial cancer, anorexia nervosa. Bulimia. Binge eating. Just binge eating. Delayed diagnosis of gynecologic cancers, anorexia, bulimia, binge eating, just anorexia. All right, and now time for our pregnancy-related complications. First is preterm birth, anorexia, bulimia, binge eating, anorexia and bulimia. Low birth weight, anorexia, bulimia, binge eating, just anorexia. And then small for gestational age infants, anorexia, bulimia, binge eating, just anorexia. Unplanned pregnancy, anorexia, bulimia, binge eating. Oh, this is a good one. Not a lot of you raise your hands. And so this is actually relevant because we may see that there's definitely menstrual disturbances across all eating disorders. And that for some folks, this can lead to, I guess that folks, because they're having menstrual disturbances, may not realize that they're ovulating and then be at risk for unplanned pregnancy. And I've actually seen this in one of my patients recently. So let's move on to miscarriage, anorexia, bulimia, binge eating, bulimia and binge eating, excessive gestational weight gain, anorexia, bulimia, binge eating, bulimia and binge eating. Poor gestational weight gain, anorexia, bulimia, binge eating. Yes, anorexia. Hyperemesis gravidarum, anorexia, bulimia, binge eating. That's just bulimia. Large for gestational age infants, anorexia, bulimia, binge eating, just binge eating. C-section, anorexia, bulimia, binge eating, just binge eating. And then gestational diabetes and hypertension, anorexia, bulimia, binge eating. That's just binge eating. All right, y'all did pretty good. So let's talk about the ovarian hormones. And this is, again, Kelly Klump's work in the past few years. And, so we have this idea that risk for eating disorders increases significantly during puberty. We also see risk for loss of control eating, binge eating disorder kind of comes online around that time as well. And Kelly has done some pretty cool naturalistic studies following naturally cycling women through the menstrual cycle. And what she has found across many studies is that from the start of menstruation to ovulation, there's a period of decreased risk for binge eating. And she proposes that estradiol is a protective factor for binge eating during that time. And then post-ovulation, we see a rise to the end of the cycle in risk for binge eating, and that follows progesterone. And so her hypothesis is that increased progesterone is actually a risk factor for binge eating specifically. And so the reason that I'm bringing this up is because obviously this is relevant for you all, but it's also relevant in terms of something practical, which is the use of combined oral contraceptives in individuals with eating disorders. And so this is actually an area that has, I think the evidence has shifted over time. And so I just wanted to take a minute to tell you all where the state of the evidence is. In terms of the use of combined oral contraceptives. So it used to be thought that maybe that the use of for underweight folks, for folks with anorexia, that it may be protective for bone health. That over studies has shown to not necessarily be true. In fact, eating disorder professionals prefer to use the return of menses as a vital sign. So having people naturally cycling is like somewhat beneficial from a eating disorder recovery standpoint. And then we also see, because of Kelly's work, she's doing some research right now investigating the role of actually contraceptives, because they're keeping folks in a high progesterone state, whether that could increase risk for binge eating in high risk samples. So I think all of that is to say, like, those are reasons why I wouldn't necessarily be jumping to hormonal contraceptives for folks with or combined oral contraceptives for folks with eating disorders. On the other side, as an eating disorder professional, if it is the thing that works for pregnancy prevention for a person with an eating disorder, use it. All of those no's don't necessarily outweigh the yeses if that's what works for that person for pregnancy prevention. And now, finally, we'll get to the menopausal transition as a potential period of increased risk. So following the model of progesterone and estrogen may be relevant for like fluctuations in risk for binge eating. There has also been some recent research suggesting that the menopausal transition may be another high-risk period for the development or the increase in binge eating among at-risk folks. So we know that there's progesterone spikes in early to mid-perimenopause, and that those may increase binge eating risk during that time. And that post-menopause there's decreasing estradiol, which may decrease the protection or the protective factor that it might be providing, and that we know that these prolonged changes can maybe shift risk specifically for binge eating. Effect sizes are currently pretty small, and we're kind of in early stages of understanding this, but I think this is an area to watch. So that is all from like the hormonal side of menopause. I also wanted to talk about, like, let's think about this from the psychological side. So in menopause, and I could actually literally take this slide and put it back in puberty, there might be small amounts of weight gain and body composition changes, right? Psychologically, that could lead to body image shifts and potentially body dissatisfaction, which then could lead to dietary restriction. So eating, specifically trying to eat less, which we know that dietary restriction and having like high levels of hunger throughout the day can increase risk for binge eating. So we have these hormonal shifts that are happening, but then layer on top of that, maybe the psychological and behavioral shifts that might be happening in concert with the hormonal shifts, and that's where you get potentially that combined increased risk. So in conclusion, eating disorders are present across the lifespan. Periods of hormonal transition may be high-risk times. This includes life phase, gender transition, menstrual phase. Psychological predispositions can exacerbate environmental vulnerability, particularly predisposition to anxiety or family history of eating disorders. And eating disorders occur across the weight spectrum. So they're underdetected and undertreated in those with higher weight, and that individual weight fluctuation may be a more important vital sign to be following rather than just absolute high or low weight. For you all, my recommendations are remain attentive to eating patterns. We already talked about the periods of hormonal change recently. That, you know, dietary restriction in vulnerable individuals is also just something to be monitoring, particularly those with history of anxiety. Eating disorders don't discriminate, so across body sizes and patients, be looking for and screening for eating disorders. And patients presenting with a desire for weight loss, you might want to consider the driving factors behind that, and that for some folks, maintaining a higher body weight may be a better balance of psychological and physical health for those folks, particularly those at high risk or with a history of eating pathology. All right, so I'm gonna stop there and take some questions. Yeah, Laura?
I have two very unrelated questions.
Okay.
The first one is, what are your recommendations for screening?
Yes.
And then both from my ease and quickly identifying patients to refer, and then also from a research standpoint, it's really tough to diagnose these. They need to be sent to someone who can actually diagnose them. But there's tons of screening questionnaires that we use for disordered eating. I'm curious about what your thoughts are.
Yeah. So I think I'm going to answer your first question, which is the clinical question. So I think you have 1 to 2 questions that you can ask patients. So I think one very simple one is what's your relationship with food, and what's your relationship with your body, right? Those 2 questions are, what's your relationship with food and your body, period. I think that kind of a question can be really effective at just opening up the door if that is something that's coming up. There are 5-item screening kind of questionnaires that can be used in clinic settings that are have you lost weight recently? Do you ever do anything to compensate for eating, that are more targeted towards individual symptoms? But if you're doing it more universally, I might just ask what's your relationship with food in your body? And then the research-wise, that one I think is probably more dependent on your specific application, because I think they range in terms of how the length, right? And so it depends on how sure you are that this is an eating disorder sample and how much in depth you want to get. One measure that I really like is called the EPSI, the Eating Pathology Symptom Inventory. And that one does not get eating disorder diagnoses, but it has probably the best psychometric validity for getting at severity in different classes of symptoms. If you're looking for a diagnosis, something like the Eating Disorder Diagnosis Scale is another shorter 10-minute scale that can be used. But yeah, happy to talk about that. Yeah.
And then the other question, I struggle a lot with, we have the anxiety and association with eating disorders, and then there's the obesity associated with eating disorders, and some of it's genetic, and some of it's through puberty and beyond. So I struggle particularly with the PCOS population because all of that is associated, and kind of figuring out what causes what. I just am curious if you have any thoughts about the genetics between anxiety and eating disorders. Is there genetics between obesity and eating disorders? Or do we know?
So that I would say that is under that's under investigation. So there is currently the first genome-wide association study of binge eating that is it should be coming out in the next 6 months. And there is association between obesity and binge eating. So in that study, and we've done some cool analyses actually that have where we kind of partial out the effects of BMI and then look at associations with other things and say is this just is a binge eating GWAS just a BMI GWAS, or is there something else? And it looks like that it's high weight, propensity to high weight plus low inhibition plus some other things that are adding to that to create risk for binge eating. Yeah.
Thank you so much. This was just great to have eating disorders sort of framed really well for an OBGYN audience. I really, really appreciate it. My question is just super practical.
Okay.
If we have someone who we're highly suspicious of an eating disorder, where do we send them in this town? Because my personal experience is that it's a little fragmented. There's not great, we've got a great program for eating disorders in this department or in this health center or this is hospital or this outpatient.
And I think unfortunately my answer to you will be that it is. I think it depends on what patient you're talking about. If the patient is under I'm going to even say 30, then adolescent medicine has a good program. And they have a lot of expertise. I think of all the departments in the university, adolescent medicine has the best expertise and best concentrated expertise in eating disorder. And they will be nice and see patients up to about age 30 because they know that they have, for outpatient care, that they have the best expertise there. So I would say, like,
Do they have therapists there?
They have physicians, they have dietitians, but they are actually doing a program right now through Mayo that is coming in to help them implement what we call like family-based therapy in primary care, so that they're like getting a lot of training around outpatient eating disorder care in primary care, so that especially for like low level patients with low level severity, that they might be able to be treated at like a little bit less of a specialty clinic kind of thing. Yes, so that I think we are trying to get we are also trying to get a psychologist embedded within that space as well, but I'll be there for the next 6 months, but long term, I don't know where that's gonna go. And then as far as therapy, I think certainly refer to psychiatry and WISPIC. I think the future of eating disorder care there is still unknown, but we'll see. Yeah. The other thing is, I actually, you know what, the other place that I would recommend for patients is there is a company called Equip that takes a lot of insurance. It's online. They do full like therapy, medical monitoring, nutrition, all in an online space, and they do adolescents and adults. And that is, I would say, like, that is a pretty accessible option for a lot of folks. It's fully virtual, but that is a good option. And then if you're talking at a higher level of severity, then there's certainly like a lot of IOP, and Rogers has a big program, that kind of thing. But again, I think my answer, unfortunately, is you're probably right in terms of that the care is fragmented. Yeah.
I mean, we have a high quality.
Yeah.
Experiences.
Yeah.
This is an area that's
Absolutely. Totally.
I just want a question in the chat.
Okay.
Can you talk about the effect of the prevalence of GLP-1 use on eating disorder rates?
I love that question because, and I would love the answer to that question. I think it is too soon to call. And as Steve Bernanke's parlance, too soon to call. I think that there are still ongoing studies on that, and unfortunately, I think we just don't have the evidence quite yet to understand the association between GLP-1s and eating disorders in those populations. I'm having a lot of actually, I have a couple of case examples that I was going to go through. If I had time, I knew I was going to have time. But one of them is this 29-year-old and who I've been seeing her for a while. We've got the binge eating under control. She's higher BMI. And worried about fertility and pregnancy, and is considering weight loss medications. And this is kind of like an ongoing conversation that we're having, that I'm also, in conversation with her psychiatrist and her doctor, because it is a really sensitive thing. And I think I've talked with her about, like, I don't want you to go on these medications and then be like, wow, I feel really great. And then that leads to like maladaptive restriction. And then we're in the same place that we were 5 years ago, right? So at this point, I think it's like a clinical individual call with patients, but I do hope that there's more research out there soon. Yeah. All right. Well, thanks.